السلام عليكم.
السلام ورحمة الله وبركاته.
My name is Faris. I'm a clinical application expert. It's my pleasure and especially for a longer time. And today lecture will be about the cardiac CT. Okay? As I was explaining before, we will be covering like the part of the technologist in terms of the steps and the understanding of the steps and phases. That, including the preparation, including some physics, including the positioning, including some screens of the protocol itself. Okay? So this should be more interactive session. So at any point you are not getting it, or if you are not very sure you're understanding it very well, please let's discuss it. Okay, so we're not going to questions today. It's like more interactive session. Okay?
Okay.
Agreed? More about I'm not going to but we can do have the slides. Here or I can show you this. Even the pathology. I'm not important. Yes, but still, it's very good to understand all of it. It's not only about that. This is my personal experience. It's very good always to know how the doctors reporting this specific procedure. It may give you the chance to give better quality. It's better report than what is for the same information that's not. Okay? So we can jump on that. Physics, very different. As I was explaining before, I agreed with taking the permission of my manager to have a post-processing session for all pulmonary branches. It will be a kind of it's like hands-on workshop. We will try to handle as much as possible. Okay? So as to make it like before that hands-on, I will be like planning with Benwell and Walid and Coronary, so as to start hands-on training. Okay? At the end of all, still you will need, but if you have less experience, you will not be able to do a full procedure by yourself after this. And even the position, the application in the pure CT machine, still that will not be like, will not be able to cover complete task. So then all we need to share information. Okay? Agree on? Okay. But I'm reaching. If you have any questions, it's like that. Okay? Listen. So, factors influencing the diagnostic performance of multi-slices CT scan. We have. That's why it's a little bit more complicated, the cardiac CT scan. It's because it's not only us, it's not only the machine, it's not only the ability of the system as well. It's as well the patient. It's the motion of the heart while we are trying to scan and be able to be diagnosed. Okay? So we go through this. Laser point is not offline presentation. Okay. I'll put you on the phone. Okay, so we need high spatial resolution so as to visualize small details. We are trying the report, the doctor will be commenting, will be reporting the stenosis of the coronaries. You get that? The coronaries. So it's not like you are reporting the heart, the muscle, the ventricles. It's the coronaries, the small vessels. It's like 2 to 3 millimeters that you need, the normal diameter of the coronaries. And you will need, the doctor will need to comment on the stenosis. It can be 10-20%, so this is like 0.2 millimeters, 0.3 millimeters. We should be able to see that. That's why we need to see a very good spatial resolution. This is the quality of the machine, the quality of the scan, and the enhancement as well. You get that? Now, the temporal resolution, it's like to limit the cardiac motion artifacts. Because we are scanning the heart, we cannot ask the patient to stop heart beating. There's no way to make that happen. Okay? So, we will need to scan while the heart is beating. So there is a motion, and there is a small coronaries, and we need to diagnose that. That's why it's much. And then, so temporal resolution, the faster ability of the machine to capture the data. You get that? So this is, it's about the rotation speed, the segment of data that will be enough to give me the image quality so as to be there. Makes sense? It's clear? Good? واضح يا شباب صح؟ And the fast anatomical coverage, this is about 40 millimeter as well. So I need to cover the whole heart as fast as possible, so as to capture the contours, the enhancement of contours. If I will be late, it will be like not well enhanced, not diagnosed. And the last one is the ECG gate. So as to be able to get these done, including the temporal resolution, how fast I will capture data. Okay, I will need to find the best time to capture the data. Okay, so now it's like if the patient heart rate is 60 beats per minute, this means 1 beat per second. This means the whole cycle, it will take 1 second. Okay. Now, in the end-diastolic phase, it will have few milliseconds, the heart preparing to pump the blood. Okay? So that's still phase. There is the least motion. I will show you a graph that it's based on that it's logic actually, but still based on analysis, the phases we can capture data that can give us still images can be diagnosed. Okay? So, in the diastolic phase, it will take few milliseconds. The heart is not moving now, there's no motion. So I need to capture data here. Okay? Now, the other chance is the end systolic phase on the right side. Okay? So I may use that. My main phase to cover, to capture data and make coronaries analysis, doctor being able to report, to comment on that one, stenosis or no stenosis, is the end-diastolic phase. So, to know this, I need to have proper tracking of the motion. You get that? So, the phases, the ECG gating, if I have proper signal, good connection, you will be able to see where is the end-diastolic. Otherwise, think about it like this. If it's compromised, not because of the heart rate, only because of the heart rate, but the ECG gate. If it's compromised, the ECG gate signal is not because of the connection, because of the position, because of the patient. Sometimes it can, rarely it can. You will think that you are capturing data at the end 75 phase, which is in the diastolic phase. This should be no motion. صح مفهوم? Okay? Now, because it's not good quality of ECG gating, it's not good signal, it will not be still images. It will be full of motion. But not actually like collecting data from the index. You get that? Okay? So, for that, I need good gating so as to get all the other features. Right? Now, because of that, if I will ask, I have ECG signal and all others, the machine is good, and the patient, for example, cannot stay still, or cannot hold his breath, I cannot do that. There is no way to do that. Don't do it. It's one of the things that must happen. Okay? this should be a video. I hope you hear it. This should show us how fast your machine, it's 0.35, the fastest rotation speed. It will show, it should show, but I may show you the video. So the next one is the so this is indicating that detector coverage. Now, I need more detector coverage to get good cardiac images now. That's because in 5 seconds, when we used to have the old machines, 10mm detector coverage, you can see my cursor. And in 5 seconds, we could cover only up to 3 centimeters. When we have that 20mm detector, 16 slices, okay, we are able to cover up to 6.2 centimeters of the heart in 5 seconds. Now with the 40mm, with the pitch of 0.25, we are able to cover 12.5 centimeters in 5 seconds. This is, you get that? So this is the detector coverage. Think about it like this. If it's like 4 centimeters and the heart size, it's about 12 centimeters. So I need how many rotations so as to be able to cover them. And this is actually adding some challenges to the other previous ones. That I need, and this is related to the ECG data. So I need to be tracking the heart cycle very well, so as to, when I will apply the detectors, the coverage, the 4 centimeter of rotation number 1 to the second one, when I will apply it, I should get exactly the same phase of motion. So as to get it in the same location, so as to get it the same continuity. There is no step artifact. That's why if the patient heart rate is changing as well, we may have this line. Okay? What have the drop?
Number of detector and size.
Detector coverage actually. So 40 millimeter is much better. Now, when we have the 16 centimeter detector coverage, the resolution, see this curve, it will be capturing the whole heart in the blink of an eye. Okay, of the rotation time, which is 0.28 and even less time. Okay, so that's how we can do it. Okay, this is showing the tracking of the motion of the 3 main coronary vessels. So this one is, these are the phases of the cycle from 0 to 100. The heart cycle, 1 beat, the full cycle. And it's showing, I may share with you the PDF. So this one, it's showing the RCA, coronary artery, and left circumflex, and this is the ostium. It's showing all the vessels. These are the ones. RCA, this is from the other one. So this is the, should be the E, and this one the LCX and the RCA. As you can see, that in the diastolic phase, 75, in the diastolic phase, it's انبساط, توسع, expanding the heart. It's really to pump. So this is at the moment, almost all vessels will be the least motion. So this is the best time to capture.
75.
75 in the diastolic phase. 75, it's fine. And if I am not able to get, mostly left side, I will not have an issue. Mostly, I do. Very common, more than 90% of my cases. I will not have an issue with the diastolic phase. With the left side. LED left side. Okay? With the anterior side. RCA, for other reasons, sometimes the diastolic phase can be the solution. So, if I need to look which one is the best for the RCA, it will be the end systolic phase. That's one. 40, 35, 40, 45. Okay? Cycle. Cycle. That's phase. Okay? So that's if I am, for example, I did complex scan for one stable patient, heart rate not high, everything is well done, and then it can happen. I have motion in the RCA. In that case, I will firstly give you the result, still images, and most probably it will be the next 35, 40, 45.
What's the normal heart rate we can do the procedure?
Okay. Usually the recommendation with almost all machines to be done to lower the heart rate.
Yes.
That's because the faster the heart beating, I have less smaller window to collect data in the industrial phase and in the assisted phase, in all phases. Okay. So it's much better to get for every patient to get him lower heart rate so as to take better data and better quality of procedure. Usually the recommendation with the 64-128 to keep it below 65. Below 65 beat per minute. Below 70, let's say. Now, can we do more than that? Yes.
But we face motion after or step after.
If you are confident enough, if you are experienced enough, you, the technologist and the doctor, they can manage it almost every case. How is that? Because he knows, okay, it will be more work, more effort to get the different phases so as to get it done, but at the end of all, you will be able to.
Yeah, and also we have phases to select on, and then if you have a good, actually, you can edit the ECG.
Yes.
For the experienced one, but for a new one, definitely it's not easy for you. Yeah.
This is including both the doctor and the technologist. If you are starting, I always recommend to prepare your patient for scan. If you are experienced enough, you will have more challenging cases. You will have like patient is not responding to beta blockers. Is not or contraindicated to be given, and sometimes they can be
Yes, angulation.
0.5 will show it. 0.23 again because I was busy, so I did not hold it enough. Sometimes it's not accurate zero because the cardiac is very, very, very accurate procedure. It will give me issues.
It should be zero.
It should be 100% guaranteed. Either by home position, the home position, or home gantry tilt. Both of them. Both of them will be easy. You get that? It's that accuracy. Okay, so this is showing the Z position, multiple scans, multiple detector coverage with that one. This is related to the previous one. So every one of them is showing where are you in every phase, okay, of the motion. But this is what this is like, because you will not take everything, you will take only this part of data, so as to put it all together and give you the full heart. You get that? So this is the industrial 70.
This one,
this
is the imaging phase.
These are the data I am putting it all together so as to make it happen.
75%.
So industrial.
Industrial.
75, 65 sometimes, okay? Clear?
Sometimes you can get it to 70 to 80, but this is the best phase.
So, do you have any questions, guys? Right. So, this is another one. This is showing the difference between retrospective gating and prospective. So, in the retrospective gating, you will be exposing the whole cycle and then reconstruct the data of the industrial phase and put it together. In both ways, you will use only the industrial phase. In both cases. So, to put it together and give it same as if it's slow motion. Correct. But in the retrospective, I will be continuously exposing. Okay. Or the prospective gating.
1.75.
For the same dose reduction, mainly, I will be exposing only the area that I like. And actually, it will not be continuous this way. It will be 1 beat exposure, 1 beat table movement, and then 1 beat exposure, and then 1 beat table movement. So the total scan time is longer than retrospective gating, but it's less radiation because the exposure is not actually it's one portion or less.
Yeah.
It should be less than 65, not to more than 65 retrospective gating. You have to do retrospective gating, and it should be no variation. As much as possible. Maximum up to 5 beats you can take. My patient is 65 beats per minute or less. And the heart rate is not variating more than 5 beats. This is a good candidate for prospective beating. Why is that? Because I need to get him this radiation dose.
Only this is the only benefit.
This is the main. Actually, it's the difference. Cardiac CT scan is high radiation. So that's why you need this. That's why everyone.
He's eligible now.
You will do your best.
First do the prospect.
Yes.
Otherwise,
Usually you should do more than like 80% of your cases prospect. This is the must.
we hope all patients.
So now there are some factors for the quality of the procedure of the lesion itself. So the diameter of segment with stenosis. So how much it is? The one I was explaining before. 10%, 20%, 50% severe stenosis. This is making it sometimes easier. The anatomy of some segment, second segment of RCA, usually the most challenging. The patient heart is not very well controlled and circumflex. And if there is calcification. Now, calcification will make it a little bit more challenging for us because the calcification, higher CT number, so it's causing looming artifact. Looming artifact. One type of the beam hardening artifact physics in CT scan. So it means the calcification itself looks bigger than its normal size, the real size, not normal, the real size, the actual size, okay? So that's why it looks, the stenosis looks more severe. So it's overestimated if you don't consider this. The CT will be overestimating the lesions if you are not considering this. Okay? Now with new machines, we have the HD, high definition. That's really reducing the glowing artifact in a good portion, and this is giving mechanism. In all angles and especially in cardiac. Now we have the quality of classification. If you are not really controlling the time, the injection, the flow rate of the contrast, that will affect the quality. Okay? The classification. Now for the patient criteria, the age of the patient is one of the things in terms of like. Sometimes the older the patient, the heart is, the normal heart rate for him is less. So that can be maybe good advantage. But still, we need him to be stabilizing the heart rate. Okay, so that's why you will consider that for the patient. The cardiovascular risk factors, this is the patient. This is actually for the diagnosis point of view for them. Which is the proper patient for cardiac CT scan. And actually, the main justification to request cardiac CT scan from the doctor, the requesting doctor, is the patient that actually two cases. The first one, the main one, the more than 90% of our cases, is the patient that the doctor thinks most probably this is normal patient. In a way that it's not okay to do diagnostic cath lab for it. Okay? Yeah. So we will go with the cardiac CT scan. Or the patient that contraindicated for any reason. It's too risky to sedate and laser, okay? Or for any other reason. So that's only the two portions where it's okay to do the cardiac CT scan. Now, before the cardiac CT scan, why the need came here? Before that, the cardiologist told me when he has a patient in emergency with the very one single symptom that it's nothing for him. He's almost 100%. This is like he has chest pain or some changing with the procedure, the other cardiac test, treadmill or ECG changes. For months happening for young patient, this is nothing. It's not. Most probably the doctor is like 90%, 95%. He knows this is normal. He cannot symptom. He cannot symptom. You know, because if after 1 week or 2 weeks or 1 month, I don't know the time. After some time, sudden death for this patient, he is the first one who they will they will question why you did not make sure. So for that specific patient, the cardiologist has to do diagnostic cath lab. Cath lab means more risk because of invasive, more money because of preparation, more staff, more time. Diagnostic cath lab is taking big portion of the procedures, and it's big cost for any hospital. You get that? That's why this patient, if the doctor thinks this is normal patient, I may not need any treating cath lab. I will not be interfering, I will not be stenting, I will not be ballooning. So he knows that this patient is a good candidate for cardiac CT scan. If your patient, if he is diagnosed, it's not okay to do cardiac CT scan. Because you will do cardiac CT scan, and then you will give him, again, you will transfer him to cath lab. So you did both. That's not the case. You get that? This is the way. The cardiovascular risk factors, the quality of veins as well. This is affecting the weight of the patient. If I have more obese patient, actually this is usually the doctors speak with the department, especially the starting cardiac, they will limit the BMI. In a certain limit I will be able to do. More than that I will not be able to do. Now that's because we are using the very fast rotation speed. So with the maximum MA I'm using, still that this is not enough quality to be diagnosed. Because mass. The more the speed, the rotation speed, rotation time, I need higher MA. So if I will apply high maximum MA, if I am having abdomen CT scan, abdominal pulse, for a very obese patient, I have volume. It's not the volume actually. I will add volume, but not because I need more contrast, because I need higher flow rate, better specification. So the higher flow rate, I have to keep that bolus time, so I will add volume. Get that? Make sense? Okay. So this is about the patient. Okay, the cardiac rhythm, it's the heart rate and regularity. Both are very important, you know now. And the diffusion of the gas, the system of diagnosis. This is what it is, okay? Now, when we have 64 multi-detector CT scan, it was really good evolution CT scan because of the better visibility. So I can do the cardiac procedure itself, all of it within 5 seconds. This was the VCT machine. This was the first one we do it for many years at that time. When it was okay? So that time it was the only machine in the world can do 5 seconds cardiac CT scan. It was okay? But that's enough to do and believe. Okay, this rhythm variability between cardiac cycles. So, because of the scan time and because of the ability of holding his breath, this will give us this variation. So, I will be getting the same condition, the same quality, the same position of the coronaries in all detector, all rotations. Make sense? Okay. This landing artifact, this motion artifact, and no cardiac pain visualization. So still I'm able to do without interface, better temporal resolution, and static spatial resolution. This is the best till this day. We have the best spatial resolution. Okay. pixel when I'm using centimeter spatial resolution. So usually the error ratio is about 1 pixel. So this is very acceptable value. We are talking about the 2 to 3 millimeter diameter of the coronaries, and the partial compensation as well. I don't want to go into deep details of physics. This is like the spatial resolution and if you get the term, it's the 3D when you are applying
Spatial resolution between differentiation between two objects across the system.
That's contrast. It's spatial resolution, signal to noise ratio. Actually, it's ability to differentiate between two small adjacent objects. Like that, small adjacent. That's spatial resolution. And in our language, it's ability to see normal CT scan, other CT scan, not cardiac. Ability to see the lesion itself and its border. So you will be able to see the border. If it's good spatial resolution. If it's not enough spatial resolution, it's blended. You cannot see the border. You cannot see that. Or let's say, better example, if there is a fissure in the bone, small one, you'll not be able to see it, to diagnose it, the doctor, unless it's enough spatial resolution. So that's the ability to differentiate between two small adjacent objects. Contrast resolution is the ability to differentiate different densities of other objects. Okay, that's about the partial compensation artifact. Partial one. Okay, now let's go to the practical patient preparation. It's the good preparation, one of the main things, and the synchronization with the ECG and the correct protocol for the when I'm talking about the correct protocol, it's about the patient size. So I will use the protocol for this size of patient and the heart again, prospective, retrospective data. So if it's like 65 or below, our variation less than 5 beats per minute. So this is like I will go with the prospective. It's okay to use. Selecting the protocol is fine. Okay? We will get it like more clear when we will start. Stability of heart rate as well, there is no advantage. And definitely the correct time. Now, if I will ask you guys, where do you think we should start preparing the patient? When we will start preparing the patient and where? Is it in the pre-arrival waiting room, or in the room, in the arrival, or on the table? Where we will start preparing the patient?
Inside the,
every patient.
Inside the preparation room, and then you even before reception.
No, that is correct. We will start preparing our patient the moment he's coming to sit an appointment.
Yes.
Because we will give him preparation instructions. Like that. That's how. This is only, I don't know, few procedures we do that, and cardiac is one. Actually, the main one. Okay. Appointment, I should either check or the doctor. We trained already the cardiologist to write it. You ask him, and it's not same as their cardiac ECG. For them, they don't ask the patient to hold his breath. For me, I need to know the ECG rate holding his breath. You get that?
It's true.
Exactly.
Yeah.
So this is the way. And yeah, you should have a paper, a written paper, instructions, and you should make sure he is getting it right. Either your receptionist is well educated, or you yourself go invest some time. This is quality. This is exactly. This is how it works. Yes, really. Discuss this with him. Just invest some time. Go sit with him. Explain him. I need this. I'm doing this because of this. I need him holding his breath, ECG, heart rate. I will give him beta blocker orally because that's doing this for me. Okay. So. Educated patient, actually the patient, and the doctor as well, he's convinced why. But then educated patient is comparative patient. Informed patient is comparative patient. That's how it works. Make sure, every single, he's not You need to think in details. Coming to this one, I will show you. Even the simplest things can compromise your procedure. You know? Think about, this is the prior to attendance. Start with the letter. It should be mentioned, no caffeine, no serious activity on the way to examination. Like he's jogging, and then after that he's coming to the appointment. That's not okay. You know, think about the simple things. Explain. You know, you need to think about the simplest things. For you, the weather, yes. Wallah, Muhammad. For you guys, if I am cardiac patient and I am wrong, think about it this way. If I need to to the way when I enter the hospital till I reach the CT room, if there are too many stairs, you should consider this. Give him prayer appointment.
Go by elevator, not by stairs.
Yes. Think about the simplest things. If he is coming to his appointment, especially it's applicable to all patients, but especially cardiac, if you know that he will be late, discuss it with him. I mean, of his appointment. Because of him, not because of you. Maybe you need more beta blocker. So you need to explain him because he is irritated now. Why I'm not going in my appointment? They are not professional. This is really increasing the heart rate. Think about the simplest things. Okay? Caffeine, it's not allowed. Should be mentioned in the preparation letter. All these things. Pre-arrival to appointment. Complete patient education about the procedure. So this is the moment when they are, even before, this is the patient preparation. No caffeine for 12 hours. Beta blocker. That's why we need to ask the patient, check the patient heart rate and decide if we will give him beta blocker or not. Instead of, you know, the patient, he's young patient, and the heart rate is high. So I know I will give him beta blocker. Why should I ask him to come and wait in my department and give him beta blocker maybe for 1 hour or 2 hours sometimes? So take these tablets. The cardiologist, it's safe. They know it's safe. They will give you the metaprolol, 50 milligram or whatever beta blocker you are using. Take these tablets one night before, in the morning before you come. It's much better chance to have him controlled. So that's less waiting. So that's less irritating. So that's better chance to get good result. So think about
This is the limit.
Absolutely yes. Absolutely yes. It's
No side effects of what is not allowed.
With any patient.
There is a
No,
way.
not allowed.
Now there is a way to consider this. My dear doctor, I need you to come and give the patient. They should. I'm talking about that concept. Okay? But you can like the policy was made for you guys and for the patients. So
Yes.
you can discuss it. No heavy exercise prior exams should be written. And even here, you know, beta blockers determined by radiologists and all cardiologists. Both of them, they are doctors. So
The radiologist.
it's yours.
Yeah.
Ensure they arrive early, don't rush or stress. Renal function tests, definitely. Send the patient, send out patient history and study information. Upon arrival, ensure they are calm, so discuss with them. Need to review the history and all the details. You have, now the moment the patient is coming, now the first thing you will do, take him to the recovery room, lie down, take resting, holding breath, heart rate, check it. From that you will decide. It's your policy. I will call the doctor. Doctor, the heart rate is this time. What should I do? I know what should I do, but I will not take decision. So what should I do? You tell you, okay, take the patient. Okay, I will come, I will give him beta. I know it's yours. It's your policy. But I should start with this. Instead of keeping him waiting for some time and then checking the heart rate, and again I will keep him waiting for the heart rate to be reduced. Discuss and evaluate breath out. Now, at this point, it's very good to start educating the patient. for me, now, my personal experience, I used to work in hospital. At this point, I will use this time to get really good connection with the patient, let him trust me. And the best way to get this done, personal experience, is communicating well with the patient. He should feel I'm doing this for you. I am giving all my attention, all my time, even if I am very busy. You cannot give this feeling to the patient, okay? Like you are not, I'm in a hurry, I don't have enough time. That's very bad. This is one of the worst things. He needs to trust you, so as to follow the instructions, so as to get good result. But he will not trust you without the proper communication. So, you know the things. Communicate.
But it's not like PNSL.
No. والله يا محمد even PNS.
هو بس انه لا هاي بدها very يعني
This is much more.
much more.
Yes. But explain him what you are doing, why you are doing it, if you can. He is really willing to know, and what you need him to do inside. So now we will go inside this procedure. I really used to say this, not with every patient. Sometimes there is no way. If he's like irritated, if he's afraid, if he's not, you will keep it simple. But some patients, they are keen to know, they want to know. They are educated, he's reading, they know what's going on. So it's very good to explain him. I will tell him, this procedure is different than the normal CT procedures because it's, it's more, you are, your cooperation and following the instructions accurately is more effective with the image quality. So I will ask for that. I will ask you to take a break at home, and you will do it every time the same way. Otherwise, you think, why he is like insisting every time to take this way? That's it. You don't think that it's really important. I will train him how to take a breath. Really? Okay. Some patients, they will take breath from the stomach. That's not good. Some patients, they will do silver. That's not good. Some patients, they are not. No. Why I need him to take a good breath? Because the more oxygenated blood will give the heart the ability to pump less, relaxed. That's why the heart rate is less. Because I'm giving the same amount of oxygen all over the body with less pumps, because it's well oxygenated. So for that, you need to take a good breath. Full inhalation, yes. But he cannot take very big breath hold, and the second time he cannot do that. You need to make it like well trained with him. Okay? Well, guys, I'm not tracking the time, Sharon. نضايق هو شوي تسلاقي قديش احنا صرنا وقت 3 طيب so now after we let the patient discuss a little bit all the breath scan within the scan of the news. This is very important. Quality of breath ECG signal is very important. So I will prepare this. This means shaving if he is male. This means I will clean it. If I have the proper gel to clean. Brand name, it's Clean Prep. Usually it comes with the machine, with the ECG kit. This is not for fun, this is not extra. This is paid. They are supplying him with the machine because it's very important. If you can, I'm sure this is not any, you don't have it anymore. Previous one. You are using this one, cardiology using it, if you have supply, it's very good to get it. Okay? Otherwise, you need to use alcohol, but you need to wait after. This is like skin preparation. Okay, I will apply a very small amount, less than 1 cc, less than half cc in every location, and dry it. Keep cleaning with the dry hose till it's gone. This is getting very good connectivity. It's not gel, we're not getting it. And we're only clean, and that's getting us very good signal from the skin, preparing the skin to be attached well and give us good signal. Very important things. Very important skin training. If you don't have it, use the alcohol with the dose, but you need to wait longer so as to make sure it's dry. Okay? This is the recommendation, it's not my experience. Okay? Good. Now, this is now in the scanner room. Think again, because he's thinking about the simplest things. So, I will get the injector and the ECG monitor the opposite side. You know why? Because the electromagnetic signal of the injector may interfere with the ECG. It's that sensitive. It's contraindicated maneuver, pivotal maneuver, to do the tube, apply the tube from the finger. You know why? Because this is interfering with the ECG. Can you imagine how important, how sensitive it is? You can find it in the recommendations. You will read it. So it's that sensitive. For ECG cardiac, very easy. For us, it's not critical. It's not I'm using the ECG signal. I'm using the ECG signal to decide where I will expose. You get that? So it's more, very much. Much more. So think about this one. Think about the connections, the leads, the cables. If you will keep it like loose, maybe it will start with the table movement, it will start to be giving hand signal. Okay? Because it's not good at that. Even the correlate of the ECG cables. Now, while we are scanning the patient, a confident take and a calm patient is the key to get a good start. Can you imagine a confident take? Confident thing. It's not telling you like a capable thing or well educated. Because if you are hesitating, this will transfer. Definitely. This is the last thing we need. So make sure one person communicating with the patient the whole cycle. Make sure from the preparation, from the beginning if you can, and make sure you are he feels that. You know what you are. Okay? Okay. In many cases, you need to calm the patient. Okay? And, okay. For example, this is my personal experience. I'm telling you, when I'm talking about my personal experience, because it may not like match. Maybe you don't want to take this. So that's why I'm trying to highlight it. It's talking about personal experience. So, you know what? One of the things, and it happened to me, especially with older patients, and not only older patients. Now, we are taking, especially in the beginning, when we are starting these procedures, it's taking longer time, sometimes 15, 20 minutes, the whole procedure, because you are preparing, discussing, checking, and then maybe the ECG is not yet, and then I'm coming back. So if you will keep a patient on the same position this way for 15 minutes, even not on the patient, he will start feeling damage. Now, the thing, really, it happened to me. It's like every time I'm getting everything almost done, and then at the last stage, I'm getting things compromised. So I started with one of the things that really enhances the result is this. So I started asking the patient, put your arms down. I'm fixing the ECG. I have to ask the patient up because the ECG, especially in the obese patient, the position of the ECG leads is very good. So I will apply it while his arms down and then up. Sometimes, especially with the obese patient, it will start touching the chin and that's it. So that's why I started to ask the patient. Arms up, position the ECG leads, arms up. Yes. I will proceed with my preparation. When I am starting the scouts, I ask the patient arms up. If I am discussing something in between, I'll ask the patient I will get to the main position with the patient relaxed. He is now it's a matter of seconds. Definitely he can handle even if it's pain. But yeah, but if I will keep him the whole time, the moment I am in the main position, either he will start feeling more pain, that's elevating the heart rate and that's compromising, or he cannot handle it anymore and he may. You get that? So it's that deep into details. Okay? Right. Discuss and evaluate with all capabilities, practice with the patient, place ECG needs and usual adherence. If the patient cannot hold his breath, you will not proceed. Okay. In the exam room, this is the patient position, patient orientation, and the center. Always make sure you are centering the patient in the proper isocenter. This is more effective in the quality in the cardiac CT scan, in the quality. Not that much. And the contrast, it's highly recommended to use the right arm, not the left, so as to get it directly the bolus of the contrast to the SPC, right subclavian to the right subclavian to the SPC, okay? So as to get this thick bolus will cause artifact. So if it's the left, it will be normal aggressive artifact because it's taking the whole passage to the SPC. You get that? The gauge, at least, we are talking about 18, but I think this is if you have warm-up, you are warm-up the contrast test. Otherwise, you need to use the 18, not the 20. ACG from the injector, the other side, and as to face the position, you need to see both ECG signals. So the dual monitor, the console room, and the ECG monitor itself from the side. Now this is the position of the leads. You will fix it with the right arm, left leg, if you have 3. And nowadays with the machines we have 4. Okay? But still it is using the best 3, the better 3. But make sure you are not applying it, positioning it on a scar of the skin. Make sure you are a little bit not close to muscles. The best position on the skin at the mid-clavicle level. Okay? And the last one and the last one. If it's not getting you the good, sometimes, mostly this will work perfectly. In some cases, few cases, you may need to consider other positions. My personal experience, if it's not working, but this is more with detail, I will use the upper sternum, mid sternum, lower sternum, and lift rib as it is. Okay? This is very good. Female, because there is no hair. Okay? Otherwise, for the baby, need to be very good. Okay? And I've seen other things. I've seen doctors, they are applying it on the back because it's on the table more next. That's not very good. I did not do that. Okay, this is the good ECG. It should be this way. This is noisy ECG signal. That's not a good way. Okay. If you have this, you may consider repositioning or including. The secret of the success, definitely what's the patient heart rate, and these are the faces that we will need. Now we will be talking about the position itself. I don't know if you want to go through this. If we have time, it will be good. Otherwise, we can keep this for the position. What do you think? I'm not sure. Which one is about the slides? I mean, شو رايك؟ كمل فيهم وجبناهم تاخذ عليهم في لسه معنا وقت انتوا كيف بدكم؟
مش عارف بس ده ممكن نعطي في برضه.
You are positioning well from the anatomical reference, sternal notch, and the table height and isocenter. And the patient heart always, it's not the mid body, it's the anterior chest. So consider this. It's applicable in all CT procedures. The better the isocenter, the better the quality on those. But in cardiac especially, it's more critical to get the heart and the isocenter. Okay? Good. Two scars, lateral and AP, and then we are ready. Now, in the breath hold instructions, I do recommend, alhamdulillah, from the old school, or this one, yeah, I tried to convince him. So all of them actually, the guys that are doing, they don't believe in that instruction. But there is a way to be done, actually. Now, it has a logical explanation, because he needs to really control how many seconds it's taking to get the minimum height. Now, I will ask the patient. Take a breath, hold. You will take a breath and hold. At the beginning, the moment he is taking a breath, the heart rate will go a little bit up, and then it will start to go down till it's the minimum. So now, by practicing this, I will know, I will find out when it is this time to scan. Okay? So that's why they prefer to use the manual. But there is a good way to be done. I will apply automatic voice instructions, but I will apply the delay after. So the system will start doing this. Take a breath and hold. This is good because it's clear voice instructions. The same voice he's hearing the patient. That's really better for the patient. Clear instructions. And I will not expose, even the scout. It will wait. I will program the protocol to hold for like 5, 6, maximum 7 seconds. After the voice, it will tell him, take a breath, hold your breath, do not scan. It will show you the countdown. 6, 5, 4. This is the time I am monitoring the heart of the patient. This is now from the first practice, the manual. It's good that the technologist is monitoring everything, controlling everything. But the other one, the automatic one, is less human errors. So I am instructing the patient, and then somebody called me, maybe this is like, take a breath and hold, and I'm not listening, or sometimes it can happen. Or for any reason, I felt or sometimes my voice is loud, or I forget to increase the loudness of the voice. So many things can interfere. Okay? And on top of that, it's very good for the patient to hear the same voice, the same instructions every time. That's much better and clear. So, me personally, I prefer that. Yes, we record that. It's not by GE messages, but we record. Okay? And then this is the lateral scout, and this is the AP scout, this is the scanning graphics. Okay? Clear? In that now, the second phase, the second run, the second city is the smart prep, calcium score, smart scoring, calcium scoring. Okay? For that, I will cover the whole heart, from the cranium till the apex of the heart. Okay? I need to be the calcium scoring 3 millimeters or less thickness. I need to be 120 kV. Even if the patient is thin, I'm not allowed to change the kV. This is affecting the read of the calcium, the result, okay? and I have to be GE requirement that DFOV display field of view 25 centimeter to keep maintaining the pixels of 0.4. Now, calcium scoring is getting the result compared to the statistics of this procedure. So it's a statistical procedure. So it's like getting this level of calcium in your coronaries will compare you to your race, to your ethnicity, to your age, to your all of these things, until you know what, for you, because you are this tribe, you are compared to these guys, you are in high risk or less risk. So for that, I need to use the same parameters, the same circumstances, so as to give the accurate result of the statistics. So that's why we need to keep it 0.4 millimeter, so the pixel size. So for that, we need to use the 25 centimeter the DFOV, so as to be giving the good result compared to your statistics. You get that? Make sense? So again, we need to be 3 millimeter or less, 120 kV, 25 centimeter DFOV. Cover the whole area, add more because it's low dose procedure, and to cover the variation of the anatomy. Sometimes the coronaries are different from patient file. That's why, okay? We will, as moment we have the images, we will start with measuring calcium, and then we will do the anatomy, because we know now where are the coronaries, so I make sure I'm covering well the anatomies because I have to do. And this is gated study. And the breathing instructions are the same. So I should have almost the same heart rate of the main position. And in diastolic phase, gated, so as to get these images. So this is in diastolic phase with the same heart rate, with the same patient, so most probably I will get the same result in that position. So because of that, this is a very good indicator for me to check the motion of the coronaries. I may, because of the calcium scoring, not very frequent, I may consider changing protocol because there is motion in the calcium scoring, so okay, I got this. This patient has different anatomy maybe, or different situation, and even with this heart rate, the RCA there is motion, so I will move from perspective gating to perspective. We can see that. I will show that. But this is one of the added value from the calcium scoring. But the main thing, we are checking the anatomy and we are checking the calcification. Now, it's not technologist decision to decide I will stop here or I will proceed because the calcium is too much maybe, but I should tell the doctor I can see some calcification, please let me know to proceed. In some cases there is calcification that may limit the quality of the procedure, and because of that the doctor will decide no, I will stop here. That? That's because there is a lot of calcification all over the whole coronaries, or there is a lot of calcification localized criteria, the main bifurcation and ED circumflex, a lot of calcification. The doctor, he will have enough experience, the reported doctor, and you know, I'm sure this one will not be able to be diagnosed by CT scan. So we will move because of that level of calcification to GANTA. Now this is an example of the calcium scoring report. It will show you which group you are from statistics. Now we have for the contrast. We have two ways to do contrast: either smart prep or mirror. Okay? Not the uniform first. Timing rules, distance. The smart prep, both of them are okay. Me personally, I prefer timing rules. That's because only one reason. Before the breathing, the main reason why I prefer the timing bonus is only because the patient will have better experience with the warm sensation of the contrast. Okay? You got that? The heating sensation. So, I have more risk of patient being irritated or panicked or afraid when he has this feeling, and that's affecting his breath hold and heart rate. That can compromise the procedure. If I'm using only the normal position, this marker. Okay? Now, why I prefer personally to have the timing bonus? Because you will feel this the first time, and it will be not as much as the main amount of contrast. So it's 20 cc. You will feel the heat, and then it's gone. Oh, okay, so this is more. So now in the main position, I have this chance to have him panic. You get that? I've seen this in cases, really. I've seen this. I moved from SmartPrep to timing bonus when I used to work in a hospital because of this. I started every time, doing everything. Prepare my patient well, everything is ready. Doing the scan, I have more ratio of patients compromised or suboptimal results or not suffering with the results sometimes because the last he kept waiting the last position. And then to analyze, and then I tried the timing bonus and I got much better result because of this. This is the only reason. You get that? But I fully agree with many people that are using the SmartPrep, and for usually in the application I do so as to reduce the cycle times. In the bonus tracking, it's single step, it's the SmartPrep, and this contrast, actually it's not this contrast, it's almost a little bit less, maybe 5 or maximum 10 cc difference between the SmartPrep and that, because I need 20 cc for the timing bonus, something like 65, okay? This is with the timing bonus. But for the SmartPrep, I may do it with 75. One injection, okay? So that's something like 5 to 10 cc difference, okay? Not a big deal. And, okay, this one. The other reason why I prefer timing bonus, the main reason I prefer timing bonus over the SmartPrep, it's less human interaction. I need to be very accurate in the moment I decide to start. Okay? With the SmartPrep. SmartPrep, if I will start instructing the patient the moment I see the enhancement in the aorta, this means the patient heart rate will not be the lowest while doing this. So I need to start with. Okay? So for that, this is how we start instructing the patient when contrast reaches the pulmonary enhancement, and whenever pulmonary aorta equivalent the same enhancement, I will be next. Because this will take a few seconds, so as to give us the patient heart rate lowest, and then I'm scanning while it's the maximum enhancement in the okay? So it's my interaction. If for any reason I have any compromise, it will affect the result. So that's more human interaction. While the timing bonus, I did 20 cc injection, and then I analyze the data, so I know the delay time, so I will apply 24, 26 seconds, and I have no interference. And even I activate in the 6 seconds to allow the heart rate to be released. So it will use. You start injection. After 10 seconds, it will start instructing. Take a breath, hold your breath, and then it will wait for 5-6 seconds, and then it's time to start. I know that this is the best time to enhance the. I have no other preference. I have nothing human dependent. I have this human terms. That's the other thing. Yes, it's you will find this variation. Okay? Now, and that just because it's physiologic, so it's really giving you the situation for this patient. That's a good time for the acquisition. We are checking the IV lines, if there is extravasation, this is extra added value. But it's extra step and more contrast. This is how we are activating the smart prep. We know how to do that, and this is how we do that. And here is where I will position my trigger location. But for both, actually. For timing bolus or for smart prep, this is the good position. Okay? This is the one. It's like just below the guide, 1 centimeter below the guide. This is the timing bolus scan. Make sure if you are using this one, the scan time, the rotation time is 1 second, the enter scan delay is 1 second, and the prepping group is usually repeat this one from 10, not 24. This is one. Correct?
20 seconds,
exposure. It's 20. I do not take the 20.
it will shoot
Exposure. It's 1 second exposure time, and we will protocol it with 20 scans. So, in the worst scan, it will do 20.
It's time to scan axial.
Yes, it's axial. Axial with 0 intervals. The table is not here. It's exposing 1 second and then waiting 1 second. And then exposing 1 second and waiting 1 second. And then exposing 1 second. That's how I can know how many seconds it will need to get the maximum enhancement. You get that? Good. Next one. For the mirror, we will need 20 cc of contrast. We will use the same flow rate of the mirror position, definitely. And I will chase it with saline as well, so as to keep the contrast enhancement. And then this is the retrospective gating. These are the 3 protocols it's using retrospective gating. Segment, burst plus. While we have only one, I will show you this one. This is the one. This is the pulse prospective gating. This is the only one prospective. These 3 are helical retrospective gating. For the helical, these are the 3. Okay? We will see that. This is the difference between the retrospective gating, one exposure continuous. This is the prospective gating. Exposure, table move. Exposure, table move. And so on. Okay? So it's total time longer, but the exposure time is this, and the dose is this. Prospective compared to the retrospective. Snapshot pulse, this is the protocol. This is the cardiac gating, this is the rotation speed, the pulse, see? This is how it works. This is the exposure total, and we will use only these data to build an image, and these data are for padding. I may shift a little bit more or less so as to get the proper stability of my face, still images. Is it getting too complicated now? Now, yes, it's getting deep now, but this will be much easier to use. You will like to take an idea. Now, trust me, guys, and especially more if you will take a look at these slides after a while. When we will start scanning, these things will be more clean and more rigid. Why I'm doing this in the protocol and why I do this in the protocol. Get that? That's it. These are the pitch level. Now, with the helical, we are using pitch. And these are the sets of pitches it's used in the protocol. We don't have control of this directly. I will show you how we can do it. Now, why I need this? Now, if the patient heart rate 70, this means it falls here. Okay? And for this, the system knows I will use segment helical and I will use 0.24 pitch. So as to get you good pitch. This is from analysis, from a lot of statistics. Okay? You get that? But
it's done by the machine.
It's done by the machine.
It choose whether it's
how? I will tell you. This is what it chooses. It selects the good pitch as per
according to the beat.
It will pick the pitch, the proper one, as per the heart rate of the patient. Okay? When is that? The moment I click on confirm. So this is what we have. I prepare the procedure, protocol, all are done, contrast is ready, I did smart print, I'm doing smart print, or I did timing bonus, all are done. Now I'm in a position. I will confirm. The patient heart rate is, let's say, 78. Okay? Now, the patient is breathing. Now, so that's why the patient heart rate is 70. I know, because I did this in the start, I did this in the practice before, and I did this with the calcium scoring as well. The patient heart rate, when he holds his breath, will be 70. Okay? The moment I will click on confirm, it will check the heart rate and decide when the pitch. I will click without asking the patient to hold breath. It will give you even not this one. It will consider this is 78 beats per minute. The patient heart rate. I will give the pitch for that. Okay? So for that, I have to tell the patient, take a breath and hold. I will wait the heart rate to get to 70, and then I will confirm and do normal patient. You get that? So now it decides the good pitch for that heart rate when the patient is holding his breath, which is the situation that it will be done in the middle position.
Even if the heart beat will return to the
now it's fine. By the moment I click confirm, it will check and decide.
Yes, confirm goes to move to table. This is
no, I will do this. My dear patient, take a breath and hold. I'm looking at the heart rate. 70. Confirm. Breathe normally, thank you. Move it. If I did it without this, it will consider the pitch wrong pitch, and that's really very bad metric. Because the pitch not the best model. Okay? Because the pitch is very, the heart rate is how fast I will be able to get the data. So it's one part of it with the helical is the pitch. So it's very critical for your patient. Okay? I have another way. I will show you later with the machine, not to make it more. These are the images, regulated neurons, phase, ECG. This is what I will keep this one for the practical one. So this is what I was explaining, pitch, confirm. Okay? This is explaining what's happening when the patient takes a breath. So usually we ask the patient, take a breath and hold, a little bit it will go, and then heart rate. And then we go to the minimum, and then we keep it mostly to the procedure. So this is like an analysis of the breath hold instructions. Usually I need to do the scan while I'm in a stable to consider after you finish. Don't forget to send images to your review, perspective reconstruction, and what Paul was explaining about ECG. Thank you guys. Sorry it's taking a very long time. I don't know the deep details. Hopefully we'll get it.